Hi, everyone. I'm Scott Nicholson with the Judy Nicholson Kidney Cancer Foundation, and I'm very excited today to have Eppie Bass with us. Eppie has been a family nurse practitioner since 2010. She has a varied background in both pediatrics and adult critical care, hospice, and palliative care prior to her work with surgical urological oncology. She meets with patients from diagnosis through the treatment path and follows up with surveillance for all urological malignancies. So when they understand the disease, the recommendations and your treatment path, they can help you reduce your fears. And so Eppie serves on the staff of Moffitt Cancer Center, and we're very excited to have her with us today. Thank you, Eppie, for joining us.
Great. Thank you very much, Scott. I'm excited to be here.
You should have the ability to share your screen now if you want to pull up your PowerPoint.
Okay. I'm going to click on the share screen, so let me know if it works.
Yes, ma'am.
Okay.
And anybody who has questions throughout the presentation, please type them into the chat box. We'll be happy to answer your questions in the Q&A session at the end. Thanks, everyone. Take it away, Eppie.
Great. Thanks, Scott. Hi, everybody. Thanks for joining me this afternoon. This talk was brought up to me to answer some questions that patients have brought up in the past about kidney cancer, about renal lesions, about what your treatment's going to be like, both surgery and if you're having systemic therapy. So I'm just going to kind of start at the beginning. Some of this may be information that you've already learned, but hopefully we can kind of start at the beginning and kind of lead up to the questions that are most important to you. So again, my name is Eppie. I've been a nurse practitioner here at Moffitt for almost 7 years in GU and do a lot with kidney cancer patients. So we're going to kind of just start. I'm going to go through the PowerPoint presentation. If you have any questions, just like Scott said, just send him a message and we'll get to those at the end. So we're going to really talk about epidemiology, and that's kind of what kidney cancer is in general, some risk factors, incidental findings. That's the most common way kidney cancers are found for most patients, or kidney lesions, the workup that's involved, the various treatment options, and then we'll get into diagnosis, staging, and some of the common questions that people have emailed to the foundation that I incorporated into this presentation. So kidney cancer in America, it is more common in people that are older adults. It's less common in people younger than 45, but we do see it in younger people as well. But it's often something that comes with age. It's a fairly common diagnosis. It is the 10th most common cancer diagnosed in the US each year. And those statistics are from the American Cancer Society. In 2020, unfortunately, they predicted over 73,000 people would be diagnosed with kidney cancer, and about 14,000 people would die from this disease. So it can be a deadly disease as well. We know some risk factors, again, comes with age. Most people diagnosed are between ages 65 and 74, again, less common in the younger people. And for some reason, males versus females are more likely to be diagnosed. 1 out of 46 men, where 1 out of 82 women. So that's pretty much a big disparity between the two. There's some thoughts that it deals with lifestyle behaviors that more men may have than women, as far as working in industries with toxins and things like that, or smoking habits. Some of the risk factors, again, workplace exposure, that can be chemical exposure. High blood pressure can be a risk for development of kidney cancer. Acetaminophen in large amounts has been shown to possibly have a link to it. It increases the risk of developing kidney cancer, but usually that's with higher dosages and long-term use. People on dialysis or with advanced kidney disease are more likely to develop kidney cancer. And there is some statistics that show a person has radiation for another type of cancer, and that's not CT scans, that's actually radiation treatment for a different type of cancer, can be at an increased risk for development of kidney cancer down the line at some point. So we know some of those risk factors are smoking. They think it's related to how much a person smokes over their lifetime. We know that African Americans are at a higher risk than Caucasians to develop kidney cancer. We do know that obesity is a high risk for development of kidney cancer, and the research feels that it's most likely related to changes in hormones within the body from being overweight. And then, of course, family history and genetics. Some of those things that you may do everything right, but if there's a strong family history or some genetic components, that can cause you to be at an increased risk as well. So most renal lesions are found, somebody goes in for to the ER, they were in a motor vehicle accident, or they're having some abdominal pain, and they get a CT scan and they say, oh, everything else looks good, but by the way, you have a spot on your kidney. So that's usually the most common way that these lesions are found, and those are called incidental findings. There are some people that go in with significant pain in their kidney, which is flank pain, blood in their urine, or they feel a lump, or they have some abnormal lab work, weight loss. And that usually is a larger lesion that they're going in for these complaints, and they happen to find the kidney mass. So some additional testing that's done, we really like to have IV contrast that really allows us to see enhancement of a lesion. If you get IV placed in the vein, where we expect to see that contrast is where we see blood flow. And whenever we have a lesion on the kidney that takes up that contrast, that tells us there's blood flow to that tumor, and that's more likely could be a kidney cancer. So we like to do abdominal MRIs, CT 3-phase, that gives us a very good look at the upper tract where the kidneys are, or a CT of the abdomen. We also include a chest x-ray. That's the normal part of workup whenever you have a kidney lesion. We know that larger tumors do have a chance to become more active and spread to other areas, and the chest is often the first place that kidney cancer goes to. And then we also like to look at your renal function. Do you have normal renal function? Do you already have impaired renal function? And that kind of helps us understand the treatment going forward. There's two types of diagnosis and staging. There's a clinical diagnosis, and that is made on imaging. So you went to the ER, you were in a car accident, they did a CT scan, and they said, oh, you have a spot on your kidney. It's about 6 centimeters. So that's a clinical diagnosis. Pathology is made on tissue. So that's actually when the pathologist has either a biopsy specimen or they have your entire tumor specimen after surgery to look at, and they tell us, what that tissue has come back as. And then staging, of course, clinical staging. Oh, you have a spot on the kidney. It looks like it's going into some of the renal veins. So that gives us a staging based on the clinical imaging. And then, of course, pathology after surgery is whenever the pathologist has the whole tissue to look at. So initial treatment options, there are some people that come in with a very small renal lesion, let's say 1.5 centimeters. We don't know how long it's been there. They've never had any prior imaging. So we can say, you know what, this is very small. We know that lesions less than 4 centimeters have a low likelihood of spreading to other areas of the body. So we say we can watch this for a little bit and let's see if it's changing, because we know that most kidney cancers grow about 0.5 centimeter a year. So these small lesions, we don't have anything to compare to. We say, let's just follow you up with another scan in 4 to 6 months. Some lesions also have some cystic components to it. They have some water, they're not solid. And we say, that's not a solid lesion. It's got a little bit of solid tissue in it, but also has a watery component to it. So let's watch that for a little bit. And then we have some patients that come in with a lot of other chronic medical conditions. Having a surgery probably would not be in their best interest. So sometimes we say, hey, you know what, let's watch this for a little bit and let's kind of see what happens along the way. We can do biopsies. Sometimes certain institutions do biopsies more than others. And a biopsy can be good if it gives us the information we need, but sometimes a biopsy needle can hit an area of the tumor and we get information that says unable to determine or not, insignificant tissue. And then sometimes the biopsy will tell us what that tissue may say. But if we're concerned enough that the lesion looks like a kidney cancer and we are recommending treatment, the biopsy a lot of times doesn't change that recommendation. And ablation, that is a form of treatment usually reserved for kidney lesions that are less than 3 centimeters, and it has to be in a good location. For somebody that wants to avoid surgery, or maybe they're a poor surgical candidate, and that's where an interventional radiologist will put a needle into the lesion, and they'll either freeze it or fry it to treat the tumor. So ablation is a way that can be done initially in the beginning as well. Surgical intervention, those are usually done by a robotic. The Da Vinci is the most common, so we use here at Moffitt, or an open procedure. An open procedure is where the surgeon will make a larger incision to actually look and have better access to the lesion. Oftentimes that's for larger lesions, or if it can't be done robotically because of positioning or some anatomical issues with the patient. But most partial nephrectomies are done via robotic procedures. So that gets us to a nephrectomy. A nephrectomy is just the word for removing kidney. So a partial is removing part of the kidney and a total is removing the whole kidney. Usually it's related to size and location. We try to preserve as much as the kidney as possible. So a small tumor that's in a location that would be easy to just kind of carve out that tumor and sew the kidney back together. We try to do what's called partial nephrectomies on that. And then there are systemic treatments. There are some patients that come in and they have a very large tumor at diagnosis. And so we talk to them about doing systemic treatment to see what the response to that tumor is.
Okay, I hear that.
And then we go through and we, after the systemic treatment, then we talk about doing surgery to maybe remove the rest. So that's systemic treatment. And that can be done at initial diagnosis, or it can be done later down the line if there's a recurrence. There's also a book that the Judy Nicholson Kidney Cancer Foundation has several copies of, and this is the 100 Questions and Answers for Kidney Cancer. So if any of you are interested in getting that book, just let Scott know. He'll need your mailing information, and they can get that out to you as well. So some of the questions, these are all questions that were sent in by you guys, and that were also have been asked to me by patients for the last several years I've been at Moffitt. And so one of the questions is, what if this lesion in my kidney is a cancer? I just have this spot. What if it's benign? And it can be benign. They're called oncocytomas. There's renal cysts. There's other types of growth on the kidney that can be benign. And that's why sometimes we watch these small lesions and wait to see if they change very much. And we want to determine, does it look more like a kidney cancer? Again, lesions that start getting a little bit bigger or are approaching 4 centimeters, we usually treat those as a kidney cancer until proven otherwise. So your physician that evaluates you whenever you go in can really talk to you about the likelihood of this being a possible kidney cancer versus it being a benign lesion, something that you could safely watch. Another question was, what if I would have changed my diet? Could I have done something to help this? And it really goes back to, they talk about diets rich in fruits and vegetables. It really helps maintain your weight. We know that fruits and vegetables have a lot of natural enzymes and immune abilities. So we always say heart healthy diet rich in fruits and vegetables. And sometimes you can do everything right, like I said, and you can still develop a spot on the kidney. So having your weight controlled and eating a diet that's healthy can help with a lot of things. One of the things is people come in and they're very anxious about that. Oftentimes they go to the ER for abdominal pain or a car accident and they're told they have this spot, and then it takes them a few weeks to get into a specialist. And during that time, they're very, very anxious about it. And I know that primary care doctors oftentimes will give somebody anti-anxiety medications. And sometimes that's needed, but those do have side effects that sometimes the people don't like to deal with. There's some non-medical medication things that you can do. There's breathing exercises. There's some great apps on if you have a smartphone, Apple or Android. They have lots of great breathing apps that can really help control your breathing when you're anxious. Reading for enjoyment instead of Dr. Google. Sometimes reading about something not related to this new finding of a kidney cancer can kind of take your mind off of it. And just going on walks, either by yourself or with friends, and then support groups. I know there's Facebook support groups. The foundation has good support groups, and there's a lot of support groups in the area, and as well as the American Cancer Society. So one of the questions was, what's the difference between a robotic and an open procedure? We kind of talked about that a little bit, but a robotic surgery usually uses small incisions, usually about 5 incisions. And the surgeon puts the tools through those incisions, a camera, another tool to visualize, some tools to cut and remove. And that surgery is done where one physician is helping manipulate those tools, and another physician is on a console that's actually looking through the camera that's inside and guiding to remove the tumor. Usually robotic surgeries are closed with surgical glue at the end. So normally sutured up on the inside, but the top of the skin is closed with glue. So you don't have the staples, things like that. And usually people recover a little bit better after robotic surgery than an open. An open procedure, again, is a an incision, depending on how long it needs to be, gaining access to remove the tumor or the whole kidney if necessary. That can sometimes be closed with glue, or oftentimes if it's a bigger incision, it's closed with surgical staples. And then surgery, a lot of people say, how long is this going to last? How long am I going to be down? When can I get back to my normal thing? So again, robotic surgery, most people do recover a little bit faster than having a large open incision. Not everybody is a candidate for robotic. So again, your physician could discuss that with you. Robotic pain, yeah, usually about 1 to 2 weeks, and then you're just sore for about 2 to 5 weeks. And the open, it's kind of double that, 3 to 4 weeks, and then the soreness where you kind of feel like your abdomen isn't hurting to do things or cough or sneeze, that suddenly is about 3 to 7 weeks. A lot of people ask about being tired after surgery, and this is one of my biggest questions that I get. And a lot of people don't realize that your kidney is your filtration system. So your kidney, its job is to filter the blood. They get about 20% of your blood flow every minute. And its job is to filter the toxins from your bloodstream and make waste, which is urine. So whenever you have surgery on a kidney, or you've had one whole kidney removed and the other kidney has to pick up the pace, it can cause a lot of fatigue because that kidney is really having to do a lot of work either by itself or after surgery. And so fatigue is pretty common after this surgery. I always tell patients, you should take some naps during the day if you need to, but get up and move and walk. You don't want to be a couch potato and just do nothing. You want to try to get up and walk a little bit, but still listen to your body and take short naps during the day if you need to, because that's okay after this surgery. You always want to make sure that you're drinking plenty of water. You don't want to get dehydrated after the surgery again. Your kidneys, your filtration system, and how you change your filter is drink plenty of water. So you don't want to cause that kidney that's had surgery on, or if you now have one kidney, to have to do extra work because we're not, drinking enough fluids and things like that. Again, when can I start walking around? Every day, get up and take some short walks. And I tell people weekly after their surgery, every week, just try to extend your activity a little bit more. You shouldn't do anything too brisk. Again, we don't want to get that heart rate pumping through that kidney that's trying to recover. Just kind of take it easy, but you want to be moving. You don't want to be a couch potato. But most people are back to their pre-surgical baseline anywhere from 6 weeks to 3 months, depending on the type of surgery they had or the complexity of their surgery. Restrictions after surgery, I tell my patients to not lift anything over 10 pounds for the first 6 weeks. So that's about a gallon of milk. I think a gallon of milk is about 9 pounds. So that gives you kind of a rough estimate what you should be lifting. Really avoid doing a lot of bending, vacuuming, the dishwasher, things like that, because you're going to be sore, and that's going to kind of aggravate everything that's been going on, and you might have a lot more discomfort. And again, you should avoid anything strenuous for about 6 weeks. So running, brisk walking, high cardiac output, playing golf. We don't want to get a lot of blood flow pumping through that kidney that's trying to recover. We want to try to keep your activity at baseline for those first 6 weeks or so. And then I tell patients after 6 weeks, just start easing back into your normal activity and listen to your body. Some people talk about gaining weight after surgery. They're not as active, they're not doing the things they were doing before. So I just tell people, drink plenty of water, but then kind of watch what you're snacking on. If you're like a lot of people, you're sitting at the house not being as active, sometimes the kitchen pantry is your new friend, and we grab things that maybe we shouldn't have. So try to keep some healthy snacks around. So if you're bored at home because you're not as active as you were before, then you can just grab some of those snacks that are a little bit healthier and avoid the high calorie snacks. A lot of people want to know when they can go back to work. It's a financial thing, right? You're having to take off work. Some people don't have enough vacation time, so they're off work without pay. So the financial part of having treatment for cancer is real. So I, tell people, if you have a job that you're sitting at a desk, you're able to really be kind of controlled in your environment. I have a lot of people that go back to work about week 3. They might still be a little bit tired, but at week 3, they're going back, they feel okay, they're not having to do a lot. And a lot of times their jobs are kind of flexible. And if they work for 6 hours and they need to go home, they go home. And a lot of times your physician or your, nurse practitioner or PA can write a letter to state as tolerated or with restrictions or whatever might need to happen. I would say people that do heavy activity, plumbers, construction, electricians, police officers that are having to wear those big heavy belts, they should really not go back to work till at least 6 weeks, because that's really just too heavy of the type of work to do. And again, your employer hopefully can work with you on restrictions, working from home, or going back. Let's say you're a plumber, but they say, hey, you know what, you can drive the vehicle, let someone else go do the heavy lifting. Then that would be great. You could go ahead and go back about week 3, knowing you weren't going to have to do any of the active work. So again, talk to your employer about that. And, you know, people talk about shoulder pain. And, you know, this is true. It's usually the gas that's used to kind of blow up the abdomen for the surgery, whether it's laparoscopic or robotic. And that does kind of cause some issues with the diaphragm. And that's where you get some shoulder pain from it. So that's very common. It usually only lasts a few days after surgery, but it can be real. That can be a big complaint that people have. And for men, they can sometimes talk about testicular pain after surgery. And this is more related when there's a lesion on the left side of the body. And it's really from drainage from the gonadal vein. And men do get testicular pain after surgery. But again, it's normally whenever there's a lesion or a kidney surgery to the left side. And some people ask, hey, I had it in one kidney, you treated it, now am I going to get it in the other? And that's a valid concern. Most kidney cancers, they usually develop as a solitary tumor in one kidney. They can develop on both kidneys, and they can have a recurrence in that one kidney in another area. But normally, most kidney cancers do have a tumor in one kidney, it gets resected, and then we follow. But again, this is why you're followed even after treatment, to make sure we don't see any new tumor on the other side, or anything elsewhere in the body. And this is a great question I get. People ask about, hey, I have one kidney now. What can I do to protect it? And I often say that even if you've got great kidney function, I think having a nephrologist, and that's a kidney doctor, in your back pocket is really, really important, because that nephrologist is going to work to make sure that that one kidney that you have stays as healthy as it can for the rest of their life. They're going to monitor medications you may be on, supplements you're taking, things that can cause the kidney to work harder. So I always tell people that have a solitary kidney, it's not usually emergent, but it's good to get set up with a nephrologist. But drink plenty of water. Again, your kidney is your filtration system, and how you change your filter is fluid intake and water. So make sure you do that. And you really want to control your blood sugar. If you think about, you know, if you're diabetic and you have high sugars, think about your blood being sticky, and that sticky blood that's trying to go through your kidney to get filtered makes that kidney work harder. So you want to really try to keep your sugar levels really controlled, and then that way your blood sugar levels are within a better range. That'll be really important for the health of your kidney, as well as blood pressure. Increased blood pressure causes damage over time to your kidney. If you think about the kidneys, again, get about 20% of your blood flow. And so if you've got higher blood pressure, that's a higher force going through that kidney. So you really want to manage your blood pressure with medication, with weight loss, exercise, whatever the primary care doctor feels, you know, would be best for you to keep those levels within a normal range. And then, like I said, there's some medications and supplements that can cause the kidney to work harder. People that take NSAIDs on a routine basis, which is Aleve, naproxen, Motrin, those kind of things. And so some people are taking these 2 or 3 times a day for months on end. Well, that can really, you know, cause some damage to the kidney, or impact the health of the kidney. So you always want to talk to your primary care doctor about the medications that you're on whenever you have one kidney, as well as if you can get seen by a local nephrologist. They'll really help you stay on top of the health of the kidney. So those were kind of the surgery questions. And then these are the questions that people asked about systemic treatment. So systemic treatment is something that's treating the whole body. Surgery is treating the site where the tumor was, and systemic treatment is treating everything in the body. And so one of the questions, you know, there's a lot of different medications. People, and there is, for kidney cancer, there's a lot of medications out there. And so there's usually an algorithm that the medical oncologist follows, and it's really, where do you start with these certain types of medications, and how do you adjust them as time goes on? There's TKIs, and those are medications that really work to block, and this slide is wrong, it's not to block the flow to the kidney, it's to block the flow to the cancer cell. So I apologize for that, but that's really how TKIs work. And they attack specific types of cancer cells, and then they cause less damage to normal cells. So TKIs are the most common type of medication used to treat kidney cancer that's usually spread elsewhere. And that's an oral pill that people take, once a day, twice a day, however it's been prescribed to you. And then there's also immune therapy. Immune therapy is a great medication to treat as well. It's actually allowing your immune system to do its job in a stronger format, so to speak. So it's allowing your immune system to attack these cells that aren't normal and to try to fight the cancer cells that way. So immune therapy is a therapy that's used quite often, and knowing which one to be on really is up to your medical oncologist. And they kind of determine that going forward. Where do you start with? When do we change? And things like that. Traditional IV chemotherapy, chemotherapy that's given in the vein, it's not the most common treatment for kidney cancer that's spread to other places. And then the NCCN guidelines is a great resource. You can actually go out there. It's the National Comprehensive Cancer Network, so nccn.org. And they have a patient information area, and it's done by cancer site. And you can actually read about some of the different recommendations. And those are the recommendations that people that are treating cancer across the United States really use to follow, to know. And they're all research-based. They also talk about different trials that are available as well. And so some people ask, how long after I'm diagnosed should I start? So if there is any kind of clinical or pathological evidence that the kidney cancer is spread elsewhere, or you're not a candidate, then the medical oncologist is going to meet with you. They're going to get some labs. They're going to kind of determine what the next step is. And they usually get you, started on your treatment pretty quickly. So if you, have a scan that's got a large tumor and it shows some sites elsewhere, you want to get into, a cancer center in your area as promptly as possible, because they're going to want to get you evaluated and get you started on some form of therapy. And here's some, kind of some of the side effects that can happen. So TKIs, that's the oral, and that's the one that stops that targets certain cancer cells. Really, the most common side effects of that are GI related. So people can have some nausea, some vomiting, diarrhea. There are some rashes that can develop, and a little bit of high blood pressure. Some of the mouth sores are the most problematic if you're somebody that gets that. There's some mouthwashes you can do and things like that to kind of help. But again, your medical oncologist often gives you medications to help limit or to reduce the side effects that could happen with the treatment. And sometimes they start you on a specific dose, and then you're having some issues that are really affecting you, and they'll reduce that dose to see if you tolerate a lower dose better. So that would be something to talk to your medical oncologist about. Immune therapy, they cause an immune reaction as part of what they're supposed to do. So it can cause some fatigue, muscle aches, some joint, different kinds of, endocrine problems. They usually give you steroids to help combat this, or sometimes keep you on a steroid at a low dose during the treatment. But again, it just really depends on how severe are the symptoms you have. And some people do have a flare and they have to be hospitalized and be on a little bit heavier steroids during their treatment, or have to come off that treatment altogether if they just can't respond, they can't tolerate the side effects. And again, talking about changing the medication, your medical oncologist is likely to start you on a specific treatment. And if they do a scan and they don't show good response to either the size that the tumor is shrinking down to, or there's some new sites of disease, then they're going to want to switch you to a different medication. And again, that's why I talked about there's usually kind of a path they follow. They start with a certain one, see how you respond, and then they know how to change from there. And then again, medication is sometimes dose reduced because, you're just not able to handle it. The patient has too many side effects at that dose. It's really impacting their quality of life. So they reduce that down and see if you can handle it better. A lot of people talk about the awful taste in their mouth. That's usually from the TKIs. You can get some Biotine mouthwash. You can get that over the counter. That can sometimes help. One of the nurse practitioners that I work with tells her patients to drink from a straw, and that actually helps put the fluid towards the back of the throat and avoids kind of the mouth. And then there's a prescription called Magic Mouthwash. That's a combination of 3 medications that you kind of swish around in the mouth, and that can help as well. So if you're having these kind of issues, make sure you don't, go through it alone. Talk to your medical oncologist and see if there's anything they can think of to help you. And financial assistance. Again, we talk about treating cancer can be very expensive, very costly for families. And so many of the hospitals or cancer treatment centers in your area will have financial assistance programs you can see if you qualify for. You can reach out to the American Cancer Society, see if there's any programs. And a lot of the drug companies, your medical oncologist will reach out to the drug company depending on your insurance and see if they have any cost offsets to help you pay for your medication. So again, don't be hesitant to reach out to your doctor and say, hey, this treatment, I want to do it, but it's financially ruining my family, and I need to know what resources are out there. And that's what they're for, and they'll help you work through different resources for you. And then people asked about prognosis by stage. And, prognosis by stage really determines on not only the stage, but the individual. So early stage diseases, those stage 1, 2, and even 3, those can have a fairly good prognosis. Either it's been treated with surgery and we're just following, or it was a higher stage, we treated with surgery and they're doing some therapy after surgery and monitoring how well the therapy is doing. So that stage can be managed pretty well. People that have stage 4, and that really means that the cancer has spread to other areas of the body, that has usually a more poor prognosis. But again, it depends on the pathology. Someone with clear cell pathology, and that's what the pathologist will tell you after surgery, what type it is, versus some abnormal high risk features, they may have a much better prognosis than somebody that has a different type of cell type. Or if this patient has a lot of other medical conditions and their body has a hard time fighting off these cells, or they're not able to tolerate the treatments that the physician would want. So not only does the stage play into the prognosis, but really what's being used and how well the patient is doing with it. And I'm a nurse practitioner, so PAs, we have a PA in our department as well. And, we work really hand in hand. I'm more on the surgery side, and we have one nurse practitioner, one PA that's on the medical oncology side. But, your role of your nurse practitioner is they may be the first person you see whenever you come in with, I just went to the ER for abdominal pain and they found this spot. So they're really going to talk to you about what that is, what the recommendations are. A lot of times they really work to maximize your other medical conditions. Hey, let's get your blood pressure better controlled. Let's make sure you're following up with your primary care doctor about your sugar levels and things like that. And they can assist with making the choice. What is the right choice for you? Is it having surgery? Is it going on therapy? Is it watching it and feeling comfortable watching it? So the medical oncologist can also really talk to you about managing the side effects of treatment. The surgical nurse practitioners will really talk to you about the surgery recovery and what to expect. But side effects of treatment, the medical oncologist, nurse practitioner, and PA do a very good job of explaining that, as well as managing those side effects with other medications if needed. And then we talk about concerns related to the treatment, related to recovery. We assist in your paperwork. You've got to take off work in a lot of cases. So you've got to fill out this FMLA paperwork, and you've got to get it turned back into your job so you can get paid, or you don't lose your job for being off and things like that. We also talk about anxiety related to the treatment because it's real and we understand that. And we want to try to get you through that without needing medication. So we have lots of different resources depending on where you're being treated. And then we also monitor you for recurrence. A lot of times, I've been here almost 7 years, and I follow patients after their surgery, every 6 months or every year, just to make sure everything keeps looking great. So, we monitor for those recurrences, and, if we see something, then we know we need to send those to the next person. And we also refer out to other disciplinary teams if you're having some chronic pain through your treatment, or you need to go see behavioral medicine because you're having a very difficult time dealing with this and maybe need some medication for, depression or anxiety. We try to make those referrals to other services as appropriate. And then ancillary support is fantastic. None of us do this on our own. You don't do it on your own. We don't do it on our own. It's a whole team. So ancillary is fantastic. You've got social work. They have great resources to help with, some financial issues and maybe some social concerns. Sometimes people, especially in Florida, they're down here and their families in Connecticut, especially with COVID right now, they don't have drivers for things. They can't get to and from their appointments for follow-up or, treatment for labs. So they're really great to work on all that. And then palliative care. Most cancer centers will have a palliative care service, and they really help with those ongoing symptoms that, can need to be managed. A nurse navigator. So not all facilities have that, but if they do, use them. The nurse navigator stays with you from the beginning and all the way through your treatment and follow-up. They're your point of contact, so you don't get lost in these big old chains of trying to call into somebody. So if you have a nurse navigator, or ask if there's a nurse navigator, use them. A lot of patients have used acupuncture, and it's really been a great resource. We actually at Moffitt have massage therapy and acupuncture therapy, Reiki. So if you have that available in your area, definitely use it. There's some low-cost acupuncture centers all around the country. I think they're called like a community acupuncture. You can look it up, and they're great to use. So you can sometimes use these, kind of ancillary support. Massage therapy can really help with stress and pain management. And then, of course, organizations like the Judy Nicholson Foundation, the American Cancer Society, they have online support groups and community support groups. So, you want to always use those resources that you have available to you. And if you don't have them available to you where you are, look for these online community supports, because they're going to be really valid to help you out through this. And I found this, I thought this was kind of, when I found it online, and we can all read it. Basically, it says, you beat cancer by how you live, why you live, and in the manner in which you live. Live your life by your own terms, not cancer's. And I thought that was really powerful. And for people that are having to go through cancer or a diagnosis of cancer and their treatment, I think that little statement really kind of speaks volumes. So I hope that you guys got something out of it that was beneficial, and we'll see what kind of questions you have.
All right, thank you so much, Eppie. If we have any questions, could we please type them out in the chat? It looks like we have a question from Brumbach. It says, hello, Eppie. I'm 23 months post-nephrectomy, and I have never had any chemo or radiation treatments. So far, after 4 CAT scans with contrast, 1 CAT scan every 6 months, I've had no evidence of disease or recurrence. My doctor's team has now suggested 1-year follow-ups. With kidney cancer, is there a timeline threshold or a goal to look ahead to?
So yeah, that's a great question. So it's really based on pathology. I'm not sure what your pathology was, but if you had a good pathology stage, say like a PT1A or PT1B, then usually it's every 6 months for the first couple of years, and then they follow you yearly. And you're usually followed for between 3 and 5 years. So again, it really depends on your stage. Some patients with a higher risk stage, like a PT2 or higher, they get scanned about every 6 months for 3 years, and then they get followed for 5 years total. And again, it's pathology based. So most all cancers are stage and pathology based, but it sounds like if you're getting scans, they've been negative, moving you out to a year. If you had great pathology is what we would do as well.
Well, did we have any other questions from the audience?
I was that good with my presentation.
I was about to say, you answered everyone's questions. J&M says that they were surprised to see that you mentioned night sweats as a symptom, and was wondering if you could explain a little bit more.
Yeah, I can explain it to the best part I can understand. And basically, so when your body, and this would be for not a small lesion, this is somebody that has a greater tumor burden, and maybe they just didn't know they had this yet. So it's your body, it's your immune system, right? It's inflammation in your body. And so night sweats is pretty common because it's your body is trying to fight this cancer cell. You don't know you have it yet. You go to the doctor for these complaints. They try to work you up, usually look at your thyroid, things like that. And then they probably end up getting a scan, and you more likely have a larger lesion. So usually that's based on your body's immune response and inflammation. And night sweats is not uncommon, but it's more common in a larger tumor that's got a greater tumor burden on your body.
I just want everyone to know that this will be our last kidney cancer conversation for the year, but we already have some scheduled for January. So we'll be continuing this throughout 2021. Our next talk will be January 13th, and it's going to be on rare kidney cancers like renal medullary carcinoma. So please look out for that. Mr. Brombach says, thank you very much, Eppie, for your presentation. It was excellent. And thank you for being with us, Mr. Brombach. And then Deborah asks, I'm 4.5 years post-surgery, stage 4, many Mets, including bone Mets, now on Cabomedics. I get 3-month scans, but have only had bone scan and brain scan 3 years ago for a clinical trial. Should I be requesting them again?
So if you develop bone pain, I think that that's a good reason to bring up, having an updated bone scan. I would assume they're doing what's called a PET CT, and that looks at from head to toe. So unless they saw an area of metabolic activity, and that's what a PET CT looks for, it looks for, do you have anything abnormal? And if you do, is it metabolically active? So if I would assume that if they saw something that was concerning on a PET, then they may say, hey, we saw this on a PET, let's get an updated bone scan. Or if you come in with complaints of bone pain, then they would most likely get an updated bone scan. As far as MRI brain, they usually update those if there's some symptoms, like you've been having dizziness or headache or losing your balance or becoming more forgetful. And I know sometimes that's hard because the medication can sometimes have some issues with forgetfulness. So I would just, bring it up with your physician. But if they're doing a PET CT every 3 months, they are looking at everything head to toe, and they're looking for changes or metabolic activity.
Deborah clarified, she said that she's never had a PET scan. They just be getting CT chest and abdomen pelvis.
Okay. And a CTAP is good too. Again, I would bring it up to your physician. I mean, you're getting scanned chest, abdomen, and pelvis, where are the most common sites that we see kidney cancer go to. So if you're concerned, or if you've had any changes as far as, in your mental health, or if you're having any kind of new pain elsewhere, make sure you bring that up, because then that would prompt them to want to get a different type of scan.
And Mark Manning asks, he said, working through big D issues as it relates to the use of Cabo, do you recommend proactive ammonium or only after issues?
So I'm not on the medical oncology team, so really understanding how they treat some of these side effects, I'm not sure. But what I can do, Scott, if you'll send me that question, okay, I'll ask one of our medical oncology nurse practitioners, and then I'll get back to you, and then you can let the patient know, because I don't want to give them this information.
That sounds good. I will do it. Well, thank you, Eppie, and thank you everyone for joining us today. I hope everyone found this informative. If you missed any part of this presentation, we will be putting the video recording on our website and social media, so please follow us there. If you do have any questions at all for either of us, please don't hesitate to reach out, and we'll be happy to answer your questions. Everyone be safe, have a happy holidays. And let's make 2021 better than this year, huh?
Yes. Thanks, everybody.
Bye, everyone. Thank you so much.